In this session, we're going to be looking at bone and joint disorders, specifically different types of arthritis and osteoporosis. At the end of this session, you should be able to describe the etiology of arthritis and osteoporosis, explain the incidence of arthritis and osteoporosis, describe the epidemiology, the pathophysiology, the causes, recognize the diagnosing of arthritis and osteoporosis, and develop an exercise prescription for arthritis and osteoporosis. The health expenditure, looking at the total costs of arthritis and other musculoskeletal conditions, are reported here from 2012. Osteoarthritis, rheumatoid arthritis, osteoporosis, and chronic low back pain, as well as slip discs, account for half of the $4 billion of health expenditure. Osteoarthritis accounts for 1/3 due to hospital costs mainly related to hip and knee arthroplasties or replacements. Prescription medication accounts for 3/4 or $215 million of expenditure for osteoporosis and half of rheumatoid arthritis expenditures. Health expenditure on arthritis and other musculoskeletal conditions increased by 5.2% between 2000 and 2001 and 2004 to 2005. What you can see here based on the 2012 statistics is it's over $55 million in terms of healthcare costs. You can see the distribution of that cost if we look at the table on the left there for total healthcare costs by condition. You can see that rheumatoid arthritis was 5%, that osteoarthritis was 40%, osteoporosis was 0.9%, and back problems was over 52% of total healthcare costs. If we look at that distribution of other financial expenses, and that includes dead weight loss from taxation foregone and government payments, you can see that we have a 63% loss in productivity, carers costs at 10%, that government costs at 19%, and other unfactored costs at 7%. So this problem of musculoskeletal problems is quite high when we look at costs. If we look at the conditions then of the rheumatological diseases, specifically we're going to look at osteoarthritis and rheumatoid arthritis. We can see that osteoarthritis is inflammatory and non-systemic, where rheumatoid arthritis is inflammatory and it is systemic. Common joints affected for osteoarthritis are the hands, the hips, the spine, and the knees, but that doesn't mean that other joints cannot be affected as well. Features related to exercise then are joint pain and stiffness and cartilage destruction, so we need to be mindful of these things when we're prescribing exercise. For rheumatoid arthritis, the affected joints are the wrists, the hands, the knees, the feet, and the spine. But again, other joints can also be affected. Features related to exercise include morning stiffness, acute or chronic inflammatory responses, pain, loss of joint integrity. And again, when we're prescribing exercise for RA, we need to keep those factors in mind. So what's the etiology of osteoarthritis? The exact cause is unknown. It can be attributed to hereditary conditions, trauma, and obesity. Now, the most common risk factors you can see there in the table are individuals older than 50. You've got crystals in joint fluid or in the cartilage that start wearing the joint down. You've got high bone mineral density that can contribute to it. Immobilization of the joint can contribute. Remember that you get that gluggy thickening of the synovial fluid, and that's not good for our joints. We need to keep that synovial fluid moving and very supple. Injury to the joint can also cause damage. There could be a crack in the cartilage, or there could be a chipping away of the cartilage that can expose the raw bone underneath. Joint hypermobility or instability. So we've got laxity in the ligaments and in the capsule that allow that joint to move around and therefore increase that potential for rubbing of the joint. Obesity is very common. If we've got excess weight on the joints, there's going to be a contributing wear and tear to those joints. Peripheral neuropathies can contribute to osteoarthritis as well, because we're not stimulating the movement or the ability in there due to loss of sensation. Also, prolonged occupational or sports stress, so that repetitive type movement, or in occupation it could be a repetitive vibration, so truck drivers or jackhammer operators, that increase in vibration can contribute to osteoarthritis as well. Okay, we can see in the picture here that we go from a nice smooth joint to the wearing down of the hyaline cartilage in the middle there, and the joint becomes very rough. You can see the red inflammatory responses. It looks quite angry. And then in the last picture, you can see the degeneration of the joint. You can see the osteophytes floating in the joint as well, that can also then increase further wearing down. In this picture, we can see that obesity and joint disorders are commonly reported through this publication. You can see the risk ratio is quite high for obese individuals for osteoarthritis as well as rheumatoid arthritis. You can also see that with osteoporosis, there's actually a dip if the individual is overweight, but as they move into that obese area, that there is an increased risk of osteoporosis as well. Looking at the management of osteoarthritis, we can see that medication is a huge contributing factor, and that the non-pharmacological, which is the exercise, actually is quite low in terms of management. And yet we'll look through a little bit further and find that the benefits of exercise are greatly improving the function and the pain management of individuals with osteoarthritis. Now, one of the outcomes of osteoarthritis at the end stages is arthroplasties, and here you can see pictures of a hip arthroplasty. So what they try to do is to replace or remodel or realign the joint. It could be a partial or a full arthroplasty that can occur. In these surgical procedures, the individual does need to go through a rehabilitation process once the surgery is finished. But saying that, we also know that if an individual has prehabilitation, if we can get some weight off of the individual if they are obese, or we can strengthen the structures up around the joint prior to exercise, prior to rehabilitation, that their outcome actually improves because of that exercise. So what are the basics? Osteoarthritis begins in the cartilage and the bones adjacent to the joint. The healthy cartilage starts to wear down and break down, and therefore we've got changes in the joint biomechanics. And you can see this in an individual who has got osteoarthritis of the knee. They actually become very bow-legged. They waddle when they walk or wobble side to side because the integrity of the joint is no longer there. And as the bones continue to rub, there's pain in the area, there's swelling in the area, there's loss of range of motion, and therefore a loss of function. So what's the prevalence of osteoarthritis? Well, we can see on the figure here that with increasing age, we have an increasing incidence of osteoarthritis. And we can see that for females, the incidence is far greater than what it is for males. Arthritis affects around 3 million Australians, or about 15% of the population. It is the leading cause of pain and disability in the elderly. It is the third leading cause of life years lost due to disability. Obesity and joint injury are important potential modifiable risk factors of OA. Obesity is also the most important predictor of progression of osteoarthritis. Furthermore, there are about 19,000 hip and 20,000 knee replacements performed each year for osteoarthritis patients here in Australia. So what are the risk factors? The non-modifiable ones are being female, 65 years plus, 55 years in male, a family history, so there is no gene for osteoarthritis. However, inheritability is about 60% for hands and hips and about 40% for knees. All races are affected. Asians tend to be lower. More knees in the Chinese, though, have been reported. If we look at the modifiable risk factors, though, injury is the most modifiable risk in knees. Meniscal and cruciate tears increase the risk by 5 to 10 times. Obesity. For osteoarthritis in the knee, every 5 kilos risk of osteoarthritis increases by 36%. But look at this, if an individual loses 5 kilos, that risk declines by 50%. Other modifiable risk factor is occupational overuse, so 30% of all osteoarthritis is related to repeated knee bending, kneeling, squatting, and climbing. If we think about individuals that perform these tasks in a job-related environment, we're going to see an increased risk of osteoarthritis. So to me, people who lay carpets, carpet layers, are at an increased risk. Individuals on construction sites that do a lot of bending and squatting, individuals climbing up and down ladders are at an increased risk, and that's just to name a few. If we look at a review of the literature on osteoarthritis and exercise, Franzen and McConnell performed a systematic review in 2008. They looked at 32 studies of 3,616 participants for knee pain and 3,719 participants for self-reported physical function. Using standardized mean differences of 0.40 for pain and 0.37 for physical function were reported. While the pooled benefits of exercise was significant based on this standardized mean difference, the magnitude of the treatment effect was actually considered quite small. However, that doesn't mean that we're not going to use exercise as a form of treatment for OA. Furthermore, Iwamoto and others went on to report in 2011 in another systematic review that strength and aerobic exercise were effective to reduce pain and improve physical function. However, what they found was adherence was the key element to success. They further reported that a program of supervised as well as independent or home exercise sessions were the best to achieve that adherence outcome that you want in your clients. Now, Ruse and Jewell in 2012, they did a systematic review and reported on 17 random controlled trials, and it was supported by 6 additional systematic reviews. They concluded that education, exercise, and weight loss were effective treatment options. What I'd like you to do now is to pause the recording here and to read the ESSA journal and to identify the current training guidelines that were developed by the American Geriatric Society and reported in Bennell and Hinman. So if you click onto that link, that'll take you to that article and you can read the recommendations by ESSA. Looking at rheumatoid arthritis now, I'd like you to take a moment to click on the hyperlink and listen to the YouTube video explanation of what rheumatoid arthritis is. If you click on the one that says "What is arthritis?" you can skip the introduction video and go straight to that one. Rheumatoid arthritis is an autoimmune systemic disease. It involves inflammation of multiple joints. They can be small or large joints. It's very symmetrical in its pattern, so if it's going to affect the right, it's going to affect the left. However, please note that rheumatoid arthritis can also affect the heart, the lungs, and the eyes. And you can see from the pictures there the different impacts that it can have. It is more common in females. The major cause of morbidity and disability is rheumatoid arthritis, and usually the diagnosis is going to be clinical or through lab. So how does the health impact on an individual who does have rheumatoid arthritis? If we look at the top of the picture talking about cardiovascular status, if the individual has an existing cardiovascular disease that's being managed, or we're trying to reduce the risk of cardiovascular disease, then by being physically active, we can minimize or reduce that risk. If they've already had a cardiovascular event, by being physically active, we can reduce the potential for another event or minimize the event should one occur. Furthermore, if we look at the bottom of this picture, we look at an individual who has little inflammation and little joint damage. They can maintain a good level of physical activity and physical ability. If there is joint damage, so moving over to the next one where you've got little inflammation and a large amount of joint damage, their ability to perform physical activity is going to be limited, and we need to use caution with our exercise prescription. If the individual is in the next phase, this active inflammation with little joint damage, they also need to have limited physical activity because they're in that acute inflammatory response, or what we call a flare-up. We need to consider or modify the exercise program, but we do not want to stop being physically active. If we move over to the right of the screen where we've got active inflammation, so again in that flare-up phase, and there is a large amount of joint damage, we also need to consider our exercise prescription, and the type of exercise that we are going to be prescribing is going to be limited as well. So the damage to the joints or the inflammatory response are going to help dictate to us what type of exercise the individual will be able to perform. Classifying rheumatoid arthritis, if the individual meets 4 out of 7 of the criteria given below, then they would be classified as having rheumatoid arthritis according to the World Health Organization. So we can see morning stiffness, arthritis of at least 3 areas, in the joints of the hand, is it symmetrical, are there rheumatoid nodules observed, is there rheumatoid factor in the blood test, and through radiographic changes around the wrist and the hands. So what is the cause of rheumatoid arthritis? Can be multifactorial, yet unknown. The evidence suggests that it is a complex association between the environment as well as genetic factors. If we look at risk factors then, females, positive family history, older age, silicate exposure, and smoking are associated with an increased risk of developing rheumatoid arthritis. The consumption of more than 3 cups of coffee daily, particularly decaffeinated coffee, may also contribute. High vitamin D intake, tea consumption and oral contraceptive use are associated with a decreased risk. 3 in 4 women with rheumatoid arthritis experience significant improvement in symptoms when pregnant, usually with recurrence after delivery. Okay, we can see on here the prevalence of rheumatoid arthritis by age and gender. Approximately 1 to 3% of the total population will be affected by rheumatoid arthritis. Women are 2 to 3 times more likely to develop rheumatoid arthritis. The onset can be at any age, but it is very common between the 30 to 50-year-old bracket. There is an association with a reduced life expectancy and increased disability. 20 to 30% of individuals with rheumatoid arthritis become permanently work disabled within 3 years of diagnosis. What if it's left untreated? Well, the individual could develop further complications, so anemia, cancer, cardiac complications, which we've already talked about, cervical spine disease and eye problems, increased infections, deformities within the joints, respiratory complications, and vesiculitis. If we look at non-medical therapies for rheumatoid arthritis, we can see that dietary modification by increasing omega-3 polyunsaturated fats will actually decrease anti-inflammatory medication use. So they work eliminating those free radicals and that inflammatory response. Exercise with the use of aerobic or strength training have no detrimental effect on disease activity. So it's not going to increase the deterioration of the joint, and it's not going to increase pain. So it's going to have a positive effect on the individual. Some of the common medications that are used for osteoarthritis and rheumatoid arthritis include this list of anti-inflammatory and pain medications. And if we look at the literature on rheumatoid arthritis and exercise, Maticios and others in 2007 reported strong evidence for exercise from low to high intensity, so it doesn't matter how hard the individual is working, on improving disease-related characteristics and functional ability. And I think that that's important to understand as individuals who've got an arthritic condition. If we can keep the muscles strong and we can keep them functioning, that they will function better in their day-to-day activities and in their daily lives. Furthermore, then, looking at Lee and others in 2006, they also reported that regular exercise has advantages for individuals at decreasing fatigue and disability. So it's quite important around that fatigue, it's important around movement, it's important around pain management. So what are the guidelines for individuals who've got arthritic type conditions? This is based on the American College of Sports Medicine. Aerobically, we want them to be using large muscle groups, so land-based, water-based, cycling, impact, non-impact, any type of aerobic activity is going to be effective. We want that 3 to 5 days a week. 5-minute sessions building up to 30-minute sessions if they've been inactive for a long period of time. We can see the intensity between 60 and 80% of their peak heart rate, which is equivalent to a rating of perceived exertion between 11 and 16 on a 20-point scale. Strength training, any type of strength training is going to be effective, whether it's isometric or isotonic. It might be dictated by pain as to whether you're using isometric or isotonic. We can see there that we want 2 to 3 reps initially, building up to that 8 to 10 repetition maximum, 2 to 3 days a week, and 2 to 3 sets of 8 to 10 repetitions. Flexibility is important. They need to be doing this on a daily basis, whether it's active range of motion exercises or whether it's stretching exercises. Flexibility is critical for decreasing stiffness and increasing pain-free movement. Functional activities as well, we want to help them to maintain their activities of daily living and to improve their quality of life. I would also look at if there is minimal joint damage to incorporate balance type activities. If there is joint damage and changes in joint activities, though, you need to use extreme caution with balancing type activities. So what do we need to consider there? Pain and swelling will reduce performance. If the individual has rheumatoid arthritis and they're in a flare-up, you're not going to be doing a lot of high loads. You're not going to be doing aerobic work. The main thing there is maintaining range of motion. If they're in a non-flare-up state, then performing regular activities will be of benefit for them. We want to avoid morning exercise in patients who suffer from morning stiffness. It might take the joints a while to get warmed up and to get moving, so it's not going to do them any good to be exercising if they're feeling really stiff and achy. We need to be cautious with overstretching. These joints are already vulnerable and already damaged, so range of motion and gentle stretching are on course. Avoiding high reps, high intensity. If pain and swelling develops, drop the intensity down, and if it continues, then you need to drop the volume down as well. Okay, here is an example of a 52-year-old male who has got arthritis. So you can see that his program is 3 days a week, and he's doing 3 10-minute sessions in that time. His intensity is between 102 and 128 beats per minute, and with him we're going to progress him up to 30 minutes of continuous exercise. And you can see that that could take several weeks or even months before we get them to that level. Strength training, 3 days a week, 1 to 2 sets of 8 to 12 reps, using all major muscle groups. Circuit training is a good activity, but again, machines and elastic bands are going to work just as well. Flexibility, looking here specifically at the major muscle groups, so his glutes, thighs, and calves, to keep the mobility in the legs so that he can do the walking exercise that he needs to do. And warm up and cool down with every session. Looking at the studies reported here on rheumatoid arthritis, walking has been used as an intervention for improving patient disease status, for the assessment of functionability via gait analysis or walking tests, and as a method to predict maximal oxygen uptake. Walking or jogging has been included in training programs without specifying the exact intensity, duration, or frequency, but no RCTs based on walking or running as the main mode of exercise have been conducted in rheumatoid arthritis. Interestingly, the case study reported above has described a female with rheumatoid arthritis who completed a whole marathon run following a training program. Patients with rheumatoid arthritis are less active and therefore less physically fit compared with healthy individuals of the same age. The most frequently used mode of aerobic exercise training in cases involving rheumatoid arthritis patients is cycling, followed by aquatic exercise, aerobic dance, walking, and running. Cycling is a non-weight-bearing activity where participants utilize large muscles of the lower extremity. It can be performed both in clinical settings as well as outdoors, either individually or in groups. Indoor cycles can be modified to accommodate the needs of every rheumatoid arthritis patient and can be effective even when patients are minimally supervised. An overview of studies using cycling is provided. Although individual studies vary in exercise frequency and overall duration of the intervention, cycling appears to consistently induce beneficial effects of aerobic activity, functional ability, and muscular strength. Looking at aquatic or hydrotherapy, there are different types of water-based exercises, such as aqua aerobics or deep water running, that have been applied to individuals with rheumatoid arthritis. The in-water environment is thought to provide the ideal means for exercising in this population, as weight bearing is minimized due to buoyancy. This is extended by the general belief that patients that this type of exercise improves their functional ability. Most of the available evidence suggests that aquatic exercise does improve aerobic capacity, muscular strength, and psychological status. The RCTs, with the larger number of rheumatoid arthritis clients combining both warm water immersion and exercise, revealed significant improvements as assessed by the Arthritis Impact Measurement Scale. However, this study did not include a laboratory-based evaluation of physical activity. Now, if we look at resistance training, a combination of intensive aerobic and strength training has been the most widely used exercise regime in recent research in rheumatoid arthritis and produces an effective physical stimulus to achieve desirable physiological adaptations. An RCT by Vanden N. and others has highlighted that combining intense aerobic and resistance training can lead to significant enhancement in both cardiorespiratory capacity and muscular strength. Other RCTs support the beneficial effects of this type of exercise in patients with recent onset, active or inactive rheumatoid arthritis. As a result of these findings, the American College of Rheumatology updated the treatment guidelines to introduce dynamic exercise as an effective means for the management of rheumatoid arthritis. What are the benefits of exercise in other arthritic conditions? You can look this up on any of the state websites or on the national website to identify this question. Still on those websites, what other arthritic conditions have been identified as well? Okay, just a reminder that World Arthritis Day is October 12th, 2014, and if you're interested in becoming involved, you can go on to the arthritis websites. Moving on then and looking at osteoporosis. Okay, the incidence of osteoporosis, we've got 1 in 2 women and 1 in 3 men over 60 years of age who will have an osteoporotic fracture. 46% in the spine, 16% in the hip, and 16% in the wrist. A fracture every 8 minutes occurs as of 2001 reporting. 2 million people in 2001 and 3 million people by 2021 will have osteoporosis. At the moment, the current healthcare costs are $1.9 billion. You've got an increase in morbidity and mortality. 20% of people with a hip fracture will die within 6 months. 6 months after hip fracture, only 15% can walk unaided. Fewer than 20% fully recover after hip fractures. Our bone mass will have a rapid loss in the early 50-year mark because of menopause in women. We can see on this slide that our peak bone mass occurs between 25 and 35, and from there on it is a slow downhill until that menopausal period where you've got that rapid loss, and you can see that steep dip in the curve, and then a continuing loss from there on. Okay, we've got a picture here of normal bone and osteoporotic bone. If we look at the endocortical surface, or the inner surface of the bone, you can see that the normal side is nice and thick and honeycombed, whereas in the osteoporotic bone you can see that there's gaping spaces and holes that occur. If we look at the periosteal surface of the bone, in the healthy bone, nice and thick, whereas in the osteoporotic bone, that's thinning down as well. If we look at the trabecular bone in the healthy bone, we can see that that's nice and thick as well. And if we look at the endothelial surface, which is related to the endocortical surface as well as the trabecular bone, we can see that that starts to thin down as well. So looking at the pathogenesis of osteoporosis, We know that bone material and the structures start to degrade with age because of mechanisms of modeling as well as a decline in the remodeling, which will eventually lead to failure. Bone remodeling or reabsorption of bone continues. We have a negative balance between the reabsorption and the bone deposits that occur. The basic metacellular unit starts to change, and we'll look at that in a minute. During growth, both periosteal and endosteal bone will increase in volume, and then in adulthood, mainly the endosteal bone will continue to remodel, but not periosteal. So if we look at that basic cellular unit, we've got the osteocytes and the bone lining cells. Now here, the osteoclasts, what they do is they eat the bone. Okay, so they reabsorb the volume of the bone, and what you have is this focal cavity. Now what happens then is the osteoblasts will fill that cavity with new bone. But with osteoporosis, we find that the volume of bone being reabsorbed is greater than the volume of the bone being formed. And therefore, you start to see these holes in the bone, and we have a decrease in bone mineral density. Okay, so at menopause, what happens is that estrogen decreases. All right, so we have an increase in bone remodeling, and therefore we have a greater decrease in bone mineral density. Estrogen deficiency will then contribute to an increase in osteoclast lifespan and formation, but a decrease in osteoblast lifespan. Men have estrogen deficiencies too, so don't forget that that's going to be one of the contributing factors for them having osteoporosis. Estrogen regulates bone resorption in men, whereas testosterone regulates bone formation. So if we look at this bone mineral unit again, we can see here the negative balance from the healthy bone going through bone loss. You can see where we have an increase in menopause, and therefore we have an increase in rate remodeling and reabsorption of the bone mineral unit and a decrease in the formation. We also have tissue mineral content decrease as well, and so that's what contributes to that hole or honeycomb look that we see in the bone. Okay, we have a loss of trabecular numbers and connectivity, so you can see that both in men and women in the picture on the left hand side. So we have an increase in reabsorption and a decrease in formation. So with women you've got this perforation or these holes, whereas in men you actually see a thinning. Sex differences due to absolute bone gained is not lost. Endosteal bone is lost, similar in men and women. Periosteal bone gained is greater in men than in women. So again, you can see those changes and where it's occurring in the bone structures itself. Okay, here is a model of the trabecular as well as the cortical bone. You can see in the men there is that gradual decline in the trabecular, the same as what we see in women, whereas in the cortical bone it's almost level in the men, whereas in the women it still continues to decline. And this is what we can see from normal as well as osteoporotic bone. And you can see on the picture on the right that fracture or that loss of bone there in the osteoporosis bone. What I'd like you to do now is to pause the slide, go on to the websites, and I would suggest you use the state-specific ones rather than the national one to identify the 6 risk factors, or identify 6 risk factors of osteoporosis, and see if you can explain them briefly. So how do we diagnose osteoporosis? We need to use a bone scan or a DEXA. The World Health Organization defines osteoporosis in expected distributions of bone mineral density for young normal adults of the same gender. There is a comparison expressed as a t-score between these normal outcomes. The t-score is a standard deviation above or below young normal mean values. Usually one standard deviation is equivalent to 10 to 15% bone mineral density values. These are measured at the hip, the spine, or the wrist. What you can see here is what a DEXA looks like, and on the right you can see the report of the screening form there. And you can see on the far right hand side, the yellow band at the bottom, that this individual had a t-score of minus 2.3, and you can see that that falls into that yellow box on the bone mineral density score. So what does that mean? Well, if we look down on the left hand side to this t-score, anything above a -1, so 0.09999 is considered normal bone mineral density. Between a -1 and a -2.499999 is low bone mineral mass, which for this individual would mean that they've got osteopenia. If you've got a -2.5 and below, then there is presence of osteoporosis. Some of the common medications used are calcium type tablets for calcium regulating to increase the opportunity for the body to absorb calcium, or HRT. Now with HRT there is no effect on resting or exercising heart rate or blood pressure. So the HRT will increase the estrogen levels in the body to help the absorption of calcium. Osteoporosis and exercise then. What do we need to consider? Load-bearing exercise will increase bone mass. The signals, whether they're hormonal or inflammatory, from the load stresses on the bone will stimulate osteoclast formation. Runners have higher bone mineral densities compared to sedentary controls. Ground reaction forces during running are usually 2 to 3 times the body weight. Triple jump is 7 times the body weight. So if we are trying to increase bone mineral density, we need to consider ground reaction force. Swimmers and cyclists have lower bone mineral density than runners do. There is research going on at the moment to try and look at these ground reaction forces, and at the moment the current recommendations are 50 jumps a day to help maintain good bone mineral density in sedentary or low active individuals. One study looked at swimmers versus gymnasts, and what was reported was that gymnasts had higher bone mineral density in the spine and femoral neck compared to swimmers. Another study looked at cyclists and weightlifters versus controls. The cyclists had lower bone mineral densities in L2 and femoral neck than age-matched controls and weightlifters. And this is interesting because if we look at the trend in cycling now, it seems to be the new golf, so to speak, for middle-aged or older individuals. And what you're seeing is that these individuals, if they do come off of their bikes, they're at an increased risk of fracturing their hips. Not good bone mineral density. Tour de France cyclists had 17% less bone mineral density than controls in this study. Okay, another study looked at mountain bikers, and they had a higher bone mineral density compared to cyclists. Again, it must be all that vibration from the impact forces. What we've got here is an individual. You can see their t-score is minus 1.5 on their spine, and on their hip we can see that their t-score is a minus 1.67. This is what a DEXA scan would look like. So the individual is definitely in the osteopenia area and at an increased risk of developing osteoporosis if that's not managed. Okay, so prevention. Okay, prevention is worth a pound of cure, and how can we prevent osteoporosis? Adequate calcium intake is quite critical. You can see on the right-hand side there the recommended daily requirements for Australians, from children all the way through to men. Eating at least 2 to 3 serves a day that is high in calcium. Glasses of milk, yogurt, hard cheeses, and nuts will contribute to improving calcium availability in the body. Another important preventive element is vitamin D. Vitamin D is needed to help the calcium to be absorbed by the body. Sun exposures of 6 to 8 minutes per day, 4 to 6 times per week, over 15% of the skin surface is quite critical to help maintaining vitamin D levels. In addition, foods such as eggs, fatty fish such as salmon and liver will also increase vitamin D in the body. Building healthy bones throughout the life is quite critical. Children need to have calcium absorption, vitamin D, as well as weight-bearing activities. And if we look at the research on weight-bearing activities, that is quite critical in those adolescent years. Furthermore, we need to look at maintaining healthy bone health in adults as well as in older adults, individuals with osteopenia, and individuals with osteoporosis. Exercise is quite important. As I've said, we need to start early. The more bone formed at a young age, the more you will have later in life. And as I said, those teen years are quite critical. Weight-bearing exercises such as running and jumping, so high-impact activities, are important for developing that bone health. Resistance training, looking at around 8 RMs, will also be of benefit. Now, if the individual already has osteoporosis, then we need to use caution with these high-impact type activities. Looking at studies then, Heinemann in 96 looked at 98 premenopausal women, and she had them performing high-impact exercises 3 times a week, and reported that bone mineral density increased at weight-bearing sites, but not at non-weight-bearing sites. Bravo in 96 used 124 postmenopausal women. They did 60 minutes 3 times a week of weight-bearing exercises, and after 1 year, bone mass loss was halted. Prince in 95 used 198 postmenopausal women. They also had calcium supplementation of 1,000 milligrams per day. The calcium plus the exercise showed the least amount of bone loss. Okay, looking at the research on osteoporosis and whole body vibration, Wysocki and others in 2011 did a systematic review, and they looked at 12 articles on whole body vibration, and their conclusion was that further research was needed. Now, I did find this research project by von Stegel and others in 2011, and they looked at the effect of exercise on bone mineral density and falls enhanced by whole body vibration. What they were able to conclude was that the exercise program did increase bone mineral density. However, the whole body vibration did not have an effect on bone mineral density. However, the whole body vibration did decrease the risk of falls in their research project. So there are some benefits there. Now, looking at Slatkovska in 2010, they also did a systematic review, and they looked at 8 RCTs, and they were able to report that there was a significant but small improvement in postmenopausal women, children, and adolescents, but not in young adult bone mineral density. So at the moment, while there is a lot of research being conducted on osteoporosis and whole body vibration, we cannot conclusively say that there are benefits, but we cannot conclusively say that there are no benefits either. So continue reading and watch this space. What are the special considerations that we need to keep in mind with individuals who have osteopenia or osteoporosis? Exercises that we need to avoid, especially with osteoporosis, are any exercise that involves spinal flexion, high impact activities such as jogging or running, or high impact aerobics, because these are going to be jarring onto the spine and hips. We need to avoid exercises that are going to increase the risk of falls. And we also need to consider that patients who have kyphosis or a kyphotic posture should be limited in terms of the stationary equipment or walking with supports, so that we don't increase their risk of falling either. We need to avoid flexion, stooping, or forward flexion type exercises, which can increase the risk of vertebral fractures. And we want to avoid unguarded exercises on unstable surfaces as well. Again, this all comes down to that increased risk of fractures and increased risk of falls. And if we have an increased risk of falls, we're going to have an increased risk of fractures. I've put this link on here for a risk screening test. I'd like you to get a family member or close family friend to take this test to see where they come up with in terms of their risk of osteoporosis. And finally, just a reminder that World Osteoporosis Day is also in October, but October 20th, 2014. And so if you're interested in being involved, you can go on to the World Osteoporosis website and to see what you can do. And questions.